Colleagues, a very good afternoon to you. Good morning. If it's not yet afternoon, wherever you are, I'm Tsepiso Magwetla. Thank you so much for joining us. Welcome to the WHO Africa media briefing in collaboration with APA Group. And just to say to you, Dr. Mwete, I believe that you're in South Africa. Happy Heritage Day to you, as well as my other colleagues who are joining us from South Africa. It is our Heritage Day here. So today we're going to be talking about the declining trend of COVID-19 cases in Africa. So we know that Africa has seen the worst of it from what some are predicting, but is this really the case? So we'll be taking a look at how the COVID-19 cases are progressing, and we'll get the latest figures as well. So let me please introduce to you our esteemed panelists. Dr. Matiso Mwete, as you know, is the WHO Regional Director for Africa. She joins us from here in Gauteng. From Edinburgh, UK, Professor Francisca Motapi, who's lecturer in Global Health and Infection and Immunity. Thank you so much for joining us as well. And also in the UK, Professor Mark Wilhouse, who is a lecturer of infectious disease epidemiology at the University of Edinburgh. Welcome to you. Dr. Sam Agatre Okwonzi, who is the chairman of the Hospital Management Board, Arua Regional Referral Hospital, that's in Uganda. And just before we proceed with the panel discussions, just a note to all of the panelists, you are going to have 3 minutes each to make your opening statements, so please try and keep to it. And a reminder to my media colleagues to use the Q&A section of the Zoom function to pose your questions. We are going to have dual interpretation in English and French. François?
Bonjour à tous et merci de vous être connectés pour ce point presse. Vous pouvez poser vos questions en utilisant la fonction Q&A et vous pouvez choisir la langue dans laquelle vous voulez entendre la conférence en utilisant l'outil d'interprétation qui est disponible en cliquant sur le globe dans les options de Zoom.
Thank you, François. So let's just go ahead and start with the conversation. I believe Dr. Okwotro will join us later on. Dr. Mwete, let me start with you. If you could just please give us a brief overview of the current situation with regards to the pandemic in Africa and the public health measures that have been taken in response to the pandemic.
Okay, first, so thank you so much, Tsepiso, and thank you to our APO colleagues as usual for supporting us with this press conference. I'd like to wish a very good morning, good afternoon to all our journalist colleagues, and thank you all for joining us for this press conference. Donc, bonjour à tout le monde. Merci de vous avoir joint à nous pour cette conférence de presse. I'm very pleased to be joined by colleagues from the University of Edinburgh, Professor Motapi and Professor Woolhouse, and also by Dr. Sam Okwonzi, who is an infectious disease epidemiologist from the Hospital Management Board at Arua Regional Referral Hospital in Uganda. Essentially to consider in this conversation the COVID-19 numbers and the response in Africa and what this tells us. And so I'll try to do that in 3 minutes and I apologize in advance. So interpreting the situation in the region is quite complex and requires a combination of metrics and tools, which I'm sure our panelists will elaborate on in our discussions today. So now, cumulatively, we've had more than 1.4 million COVID-19 cases reported on the African continent, and unfortunately 34,000 people have died. And what we've seen is that even before the first cases were reported in Africa in February, and that was in Egypt, at WHO we were working with governments and partners to ramp up preparedness and response capacities for COVID-19. Almost all countries had established testing within a few weeks, and this was after only 2 countries at the beginning. There'd been a lot of training of healthcare workers in surveillance, infection prevention and control, in case management with support from ourselves in WHO and from other partners. I have to say in WHO, we've invested a lot of our technical resources. We have 900 staff members in the African region that have been repurposed mostly from our country offices and also from the regional office. And from senior management, I have to confess I've hardly done anything else except work on the COVID-19 since March. We provided advisory and material support, helped them with the procurement of personal protective equipment, test kits, and other essential supplies. And we've been able to mobilize more than $320 million from our international partners for the response in Africa, and also worked with the Africa CDC and others to support governments. One thing that made a big difference, we believe, is that from March, so quite early on in the evolution of the pandemic on the continent, governments quickly implemented restrictions on movement and gathering, the so-called lockdowns. And this, we think, created a window of opportunity to keep the case numbers low and also to strengthen public health capacities. After starting to ease restrictions in May and June, in an effort, clearly an imperative really, to protect livelihoods and economies, countries have started to reopen. And some countries like South Africa, Algeria, Mauritania, Ghana experienced an increase in COVID-19 cases. And now we are seeing in most countries in the region a decrease in cases. So some studies are underway to test if communities have antibodies, really to answer the question, are we missing very many people who are infected and not detected? And some early results suggest a higher number of infections than those that are reported in countries like Kenya, Malawi, and Zambia. And but to extrapolate these findings to the national level, we think that further research is needed, going beyond urban areas, including in rural areas where transmission seems to be lower. Our preliminary analysis suggests that over 80% of cases in African countries are asymptomatic, which is a bit higher than the asymptomatic rates that are being quoted around the world. And this is reinforced by the fact that we have not seen health facilities and health systems overwhelmed by very large numbers of cases. And we're also not seeing evidence of excess mortality due to COVID-19 or missing deaths. And we believe that even though we acknowledge that death registration in most of our countries is a problem, we have seen in previous outbreaks like the West Africa Ebola outbreak that when communities start to see many numbers of people dying of a particular pattern of illness, they report this at some point or other in the health system. So overall, just to conclude, we'd like to recognize that governments took early, quite drastic action through the lockdowns at great cost to their economies, clearly, and this has bought us some time. They are now at the point of relaxing these restrictions, which really demands then two things: that the public health capacities should be up to speed all over countries to be able to identify cases, to test and isolate them, and to find their contacts and isolate those. And also that all of us, people, should know and understand what we should do to limit the transmission, meaning to avoid mass gatherings, keep a physical distance, wear masks whenever it is important, especially when we are indoors, but also in public places, frequently wash our hands, and very importantly, shield older people and those people who have underlying conditions from being infected. So I look forward very much to discussing with our panelists what we think is going on in the region, and most importantly, what needs to go on into the future so that we help our countries bring an end to the transmission of this virus. Thank you very much, Tsepiso. I'll stop there.
Thank you very much, Dr. Moeti, and I'm sure there is going to be a great deal of interest and questions around some of the issues that you've raised. 80% of Africa asymptomatic, and we're talking about low numbers, as you say. Just how low are they really? Well, you have also spoken about the importance of partnership, and we're going to see what role academia has played and how they've partnered with you in understanding the disease and the trends. Professor Francisca Mutapi, as I mentioned, is with the University of Edinburgh. Let's hand over to you, Dr. Mutapi. What can you tell us about the TB epidemic response, what you're doing, the work that you've been involved in?
Great, thank you very much. Good morning, and thank you for the invitation to participate this morning. Yes, so I'm going to just highlight some of the important roles that universities and academia are playing in generating information to better understand and respond to the COVID-19 situation in Africa through research, analytics, capacity building. And I'll use examples from our own work from our Africa-led partnership, Tackling Infections to Benefit Africa, or TIBA. The Swahili journalists will know what that means in Swahili. So TIBA is a partnership of 11 research institutes. 10 of these are in 9 African countries, and 1 of them is in Edinburgh, which is why you have myself and Professor Mark Woolhouse here. Prior to the pandemic, TIBA was already working closely with ministers of health in Africa and our colleagues at WHO Afro to support health initiatives through generating scientific evidence and policy and practice through availing our expertise and resources as well. Our work on the pandemic is just an extension of our pre-existing work on Work Package 6, where we've been working on epidemic preparedness in Africa, ensuring that our colleagues in the 9 African countries are empowered to respond to any emergency such as this pandemic. For this, we have used extensive data collected through our colleagues, such as our collaborators in WHO Afro and other stakeholders, to add value to the data by applying our big data analytics as well as modeling expertise. Examples of the work we have done to support governments directly and through our collaboration with WHO Afro include the following, but are not limited to those. So firstly, mobilizing human resources to strengthen the COVID-19 response, building on the lessons that were learned from Ebola, generating evidence for the need for the provision of medical oxygen. We've used quite a lot of data from WHO Afro to guide member countries on how to provide the oxygen they need. Working with TIBA Zimbabwe, I have been leading a research program on testing of frontline health workers, which has led to significant government policy just last month in Zimbabwe. So really impactful work. We've also been looking at SARS-CoV-2 sequencing, where we have both directly provided support and technical assistance to our colleagues in Africa so that they could do their own sequencing in-house. But also we've been really working very hard on bioinformatic analysis of all the sequences that are currently available from African countries. So these are available in public databases that can be accessed by anybody. We've also been looking at the comparative analysis of the mitigation strategies that Dr. Moeti mentioned in her introduction of what the government's responses were. So we've been looking at what these were, what worked, what can be adapted by other countries, and more importantly, what's the impact and uptake as well as compliance of those were. So again, we can discuss a bit on the impact of that. And finally, we've been analyzing the progress as well as characterizing the epidemic. So we report this in a weekly situation report for WHO Afro member states. And this really is the crux of the discussion that we're having today of what these kinds of analytics have been showing us. So for what we've been doing with this data and some of our findings relevant to the topic we're discussing today, I'd like to pass you on to my colleague, Professor Mark Woolhouse, who's our director at TIBA, but I will let Tupiso do the introduction and lead us into Professor Woolhouse's presentation. Thank you very much.
Tupiso, you're muted, I think.
Thank you very much, Dr. Moeti. I don't know what happened there. I was wondering. I was saying Professor Motapi was actually co-moderating with me, which I didn't mind at all. So maybe that's why I stayed muted, Professor. Thank you so much. And indeed, let us get into the meat of it, the technicalities of it, as you say. Professor Francisca Motapi, thank you very much. Let's now pass on to Professor Mark Woolhouse to talk about your perspective on the sequencing, the data analysis, the use of Google mobility, I believe, to monitor people's behavior, all of that. So please go ahead and introduce us to that, Professor Woolhouse.
Thank you very much, and good morning, everybody. Thank you particularly to Dr. Moeti for the invitation to participate in this event. So as you've been told, I'm Director of TIBA, and you've been told a bit about that. I should mention that at the beginning of this pandemic, our funders, the National Institute for Health Research, TIBA's main funders, immediately gave us permission to divert our resources to supporting WHO-AFRO and other national governments in our partner countries to try and tackle this international health emergency. As you heard from both Dr. Mweti and Professor Mutapi, data is at the heart of this. And so we've been looking at data and linkage of multiple data streams and analytics. Our epidemic data comes from WHO-AFRO, and I really should say here that I am in great admiration of the WHO-AFRO teams and the timely data updates they provide and the information. And it's not just for COVID-19. They've been doing this for a long time. The WHO-AFRO situation reports are a very authoritative source of epidemic data for the whole continent. And I think we should be very grateful to them for what they've done there. So we're doing some basic epidemiological modeling in real time, basically to track the upturn of the epidemic. The usual metric you use for that is something called the doubling time, how fast cases double, how fast deaths double. Happily, in Africa, we didn't use that metric for very long. The epidemic started to peak after some weeks or a couple of months, and we're starting using a different metric, which is called the weekly ratio, which is simply whether or not there are more or less cases this week than last week. We use the same metric in the UK as a very simple way of monitoring trends. And we are producing reports every week on those trends so that our colleagues at WHO-AFRO and everyone else can see that show clearly how different African countries are performing according to those evaluations. We can also start to monitor, just as Dr. Mweti said, how Africa is getting back to normal. And we have done a very in-depth data collection exercise of what measures are in place in different times in different African countries. But of course, as we all know, in any government around the world, what the government says is one thing, what the people do is maybe not exactly the same thing. So it's useful to have independent ways of assessing that. And an extraordinarily useful tool for that being used around the world is Google mobility data. I won't go into the details now, but it uses data gathered from where people are based on their phones. It's completely anonymized, it's publicly available. And this is very helpful in us understanding how Africa is getting back to normal. And indeed it is getting back to normal, but as I'm sure Dr. Mweti will confirm, not fully back to normal yet. And so that's an interesting thing that we've seen many African countries start to return to normal, and many of them without a resurgence in cases, but we're not quite there yet. So we do need to be very careful. This sort of analysis is, I hope, useful to our WHO colleagues in real time. But the other incredibly important thing to do with all these multiple data streams is to learn lessons. Africa's had its own epidemic. That's why we're here today to discuss that. I've worked very closely with the epidemic in the UK and elsewhere in Europe as well. They're different. They have different characteristics. So I think there are going to be lessons to be learned from all this data from Africa for Africa. And I think it's very important that we continue to work along those lines, and we will do so when asked by our WHO-AFRO colleagues. Thank you very much.
Thank you very much, Professor Wilhouse. Thank you very much indeed. And we did mention at the very onset that there are 4 panelists. Dr. Sam Agatre-Okuonzi is the chairman of the Hospital Management Board, a regional referral hospital in Uganda. And Dr. Agatre is going to talk to us now about the region itself. We've been talking about modeling. Professor Wilhouse there saying that Africa has had its own pandemic. So let's hear a little bit more about that from the Ugandan perspectives. Look at the informed decisions data has been allowing them to make in terms of the importance of modeling the infectious diseases outbreaks by countries. Dr. Agatre, very warm welcome to you.
Thank you very much. Good afternoon, everybody. I just want to say something a little bit about the modeling and the predictions that occurred much earlier in the pandemic. At the beginning of the pandemic, of the COVID-19 pandemic, the outbreak, there was a near universal concern for countries that are perceived to be poor, particularly African countries, and those that we are seen to be having weak health systems. And the initial disease predictive models painted a picture, a very bleak picture of severe devastation of lives and economies in Africa. In Uganda here, there was panic. In Uganda, it was predicted that by September, by the beginning of this month, there would be 600,000 cases of COVID-19 and 30,000 deaths by this September. But the reality is starkly different. The reality is that by September now, by the beginning of September, we had 2,500 cases, roughly, and 32 deaths, 32 deaths. Similar observations have been made in other African countries. Now, the predictive COVID-19 models are actually based on European populations, not on African populations. And they are also informed by very well entrenched biases about Africa. That, for example, Africa is prone to disease. The African person is a person who carries disease. That the biases include Africa being naturally the home of disease. And Africa is a place where this kind of disease would flare up most. A friend of mine actually called me from Italy at the peak of their epidemic and said they don't understand why Africa is so protected when we're on fire here. He just could not understand. So COVID-19 has shattered a lot of biases about the disease in general, but also about Africa and about Africans being human, just like anybody else. The rate of COVID transmission and severity of the pandemic has not played out in line with these outrageous predictions. It has not. There could have been some underreporting, I agree, of cases because we don't have a good system. Some of the systems are not good to collect data, but you cannot suppress deaths. The deaths that occur in society are so loud and so visible that you can only conclude that they must be accurate, and there are very few. So the most probable factors for a lower transmission and disease severity include, for example, youthful population, possibly an inherent immunity, possibly something to do with temperature and altitude, possibly something to do with better population response, because we have a lot of experience from Ebola and other diseases, and people are prepared for some of these outbreaks. In fact, some of the best performers on the Global Health Security Index are now African countries, such as Tanzania, where many people seem to be very sad that they are not providing information. Some of these countries include Rwanda, Senegal, Sierra Leone, and Liberia. And many of these countries, in fact, were at the center of the Ebola epidemic. These countries have played better in health security than powerful countries like USA and UK. So unbiased models based on African statistics and trends need to be used for COVID prediction and for policy making. And I want to agree with my colleagues who have just mentioned here that universities play a big role in this research. So it is really up to us as researchers to characterize this disease in Africa and not look for comparison with other countries or use other countries' statistics to project our own characteristics. So what we need is data, we need to analyze trends, and we need analytics to inform us of how best we can predict and put policy for the on the future of this epidemic. Because now we are moving to a new phase. I'm not quite sure that we can say it is coming to normal, but it is not as severe as it has been in other places. So let me just stop here. Thank you very much.
Thank you very much, Dr. Obonzi. Very much food for thought in what you've said, giving us the African context. And I think it's answered quite a number of questions, especially around the modeling, which I know a lot of journalists have. And speaking of that, colleagues, please do use the Q&A. Pose your questions. Remember, you can use that globe icon at the bottom to get your English or French translation as well. So let's just go ahead then and ask some of the questions that have already been sent through. And I think from what Dr. Obonzi was saying, this question from DPA Germany, I think it's Jola Foster, speaks to some of the issues that he has raised. Dr. Moeti, let me pass it on to you because you also spoke about this. So Jola wants to know, I mean, how do you explain some of the anomalies that we're seeing according to Giola? The number of antibody studies is showing that the infection rates of the coronavirus, official number that the numbers are higher. However, Giola says that the number of very ill patients and deaths are low. How do you explain this? Dr. Moeti, would you like to answer that, please?
Okay, thank you very much. And first, I'd like to thank my fellow panelists for really excellent introductions to this topic that we're discussing today. I think this question, how do we explain that cases are lower, whereas infection rates seem to be higher? I assume that's referring to some of the surveys that have been carried out. There have been a few surveys carried out, and relatively few surveys carried out, we need to say, and mainly those have been carried out among special groups or in some urban areas. I think we also need to look at how the surveys were carried out, what sort of tests were carried out. We have a range of testing technologies and kits, some of which have challenges in terms of their performance in relation to false positives or false negatives. I think we need to take all of that into consideration. I do think that in terms of impact, particularly fatalities are concerned, I think that the population structure does make a lot of difference. In the African region, or in most African countries, we have about 3% of the population aged over 65 years. And then if we look at some of the countries that have had higher mortality rates in Africa, Algeria, for example, which is a country which has kind of gone through its demographic transition, where you find about 10% of the population is over the age of 65. South Africa, where that figure is about 5%, where of course, as far as Africa is concerned, the South African situation has been different from any other country in terms of spread and in terms of the size of the pandemic. Here we do see higher proportions and a higher case fatality rate than we've seen in other countries. So we think that the age structure makes a difference. And this is something that we had to learn as we observed the pandemic. I mean, to come back to the issue of modeling, at the beginning, before we had enough information about what are some of the drivers of, if you like, people tending to then progress to be seriously ill and people dying of the pandemic, we did not understand at the beginning the importance of the age structure and age. in the fact that young people may be infected, but in fact, they're relatively, it's more unusual for them to get seriously ill and for them to die of this illness. So I think that those are some of the factors that are very much at play. I mean, and just to say something to our colleague, Dr. Sam, and his comments about how the modeling needs to take into account the realities of the context of the African population. I think some of the early models perhaps were based on what was going on elsewhere. I do think work is going on to adapt these models. So some of the modeling that we did in WHO, for example, where I guess we also started off with if there's not much happening in terms of public health interventions and we have widespread community transmission happening, what do we predict will happen in terms of cases and deaths? And we came up with numbers that are very much higher than what we have seen. I do think what's made a huge difference is that other factors being the fact that apart from a few countries, South Africa and some of the North African countries, Africa is less internationally connected than many other regions. So if you look at most African countries, how many flights a day come in internationally, it's very different from countries like South Africa or some of the other countries in the region. So we had, I believe, some sort of protection from when the virus first landed here. And there are other factors, ability to move around within countries, the road networks, the numbers of cars per capita, all of this makes a difference in terms of how intensely the virus is going to spread within countries. These are all factors that we need to take into account. When we look at elderly people, we do have some elderly people. They tend in African societies to be living at home. So one of the big driving factors in Western countries was the fact that the elderly were living in specialized homes, and these themselves became places where the transmission was very intense, and many people among the elderly died because they were living in these kind of circumstances. So we're learning every day, is what I'll say.
Thank you so much for that, Dr. Mweti. I'd like to again remind the colleagues that the Q&A section is available to you. In fact, I see that we've got a question from Jean-Richard, it's in French, and we have Dr. Humphrey Karamagi, who's already responded to you, Richard. So just to let the others know that if you feel that you're not going to get your answer right here and then, but we do have experts, colleagues who are also part of the conversation who can do this. So let me move on to the next question then. And Rochelle Akufo from CGT and America in the US writes in, I think it speaks to very much what Dr. Okwonzi was saying earlier on. You are saying that a lot of people have been surprised by Africa's success in containing and combating the virus and thus avoiding scenarios. What do you attribute it to? What was said earlier on is that there could possibly be the issue of inherent immunity, better population response. But I'd like to get Professor Mutapi to just speak through the TB experiences that you mentioned earlier on, if you could answer this question.
Thank you for that. So from our own analysis in trying to find out why the response has been better, and from the comparative work we've done looking at mitigation strategies across Africa, one of the other factors about the virus is it doesn't transmit very well outdoors. And Africa has a significant population that is rural and spends a lot of time outdoors. So that's one of the factors that we have found from our own work. In terms of cross-immunity, we have just started the big study on that in Zimbabwe to find out the responses of the population to the other 6 previous coronaviruses. So if you invite me back in about 3-4 months' time, I will have a better answer to let you know what the levels of cross-reactivity and potential cross-protection for that is. I hope that answers the question. Thank you.
I'm sure we will. Thank you very much, Professor Mutapi. And let's winning from Waiter South Africa asking this question. And the question is, you mentioned earlier on, Professor Wuhas, about the value of the WHO situational report. So using that data, Alexander is saying, so the analysis shows the reasons, whether immunological, structural, or otherwise, for lower than expected COVID-19 fatalities on the continent. So are you able to share a little bit more from the data that you gleaned?
Thank you very much. So the data are incredibly valuable, but we do have to be very careful how we use them. On a day-to-day basis, all countries are reporting cases and deaths. It's very noisy. It's very noisy data. So it's important that we understand the context in which the data was collected and that our statistical tools are robust enough to deal with the noise in the data. We produce a map that shows where in Africa the epidemic is in decline. And we color the map with different countries that are green, but that map actually changes from day to day because the data is so noisy. So you have to look at trends over a reasonable length of time. Dr. Mweti was speaking earlier about, I think, the need for caution, Dr. Mweti, as we relax. I mean, here in the UK, we required that our epidemic indicators were all green, if you like, that they were all pointing in the right direction for 3 consecutive weeks before we were satisfied that we could think about relaxing some of the restrictions. And that was one of the things introduced by the government here. There was a question in there about immunity as well. As Dr. Mweti says, I think the serosurveillance so far in Africa has been very patchy and quite specialist, as in it's been aimed at healthcare workers or particular subpopulations. So we do need to be tremendously careful how we interpret that. While I agree with Dr. Sam completely that we shouldn't assume that what we find in Europe or Asia applies here, I think we can still use some of the information. And one of them is that healthcare workers are particularly heavily exposed to this virus. And when you do a serosurveillance survey, you will get an exaggerated picture of what's going on in the community. So I think we have to be cautious with that data, but it is coming and hopefully it will be valuable over the coming weeks and months. Thank you.
Thank you very much, Professor Woolhouse. And we move on to this question from Rhoda Odhiambo from BBC Africa in Kenya. I think it very much continues the train of thought. And Dr. Sam, you mentioned it earlier on, and perhaps you'd like to continue with that conversation. So Rhoda's question is, does the WHO know whether the strain of the virus that is circulating in the continent is similar to the parts of the world? How many strains are circulating in Africa? So you did also mention the issue of why we're seeing differences. Dr. Mweti, I'll come to you to also respond to this, but let me start with you, Dr. Okonzi.
Well, I'm not familiar with the current trends. The work that is being done in Uganda here is ongoing, and they are trying to identify the strains. From what is coming out from the Uganda Virus Research Institute, it appears that for every country, or perhaps for Uganda, the strain is unique. Apparently, due to mutation, every population may have its own strain. So this work is still ongoing, and we do not exactly know the number and the types of strains that are coming out, and also what the characteristics are going to be like. But from what we see, generally it has been a subdued outbreak, and the deaths are much, much lower. And we're actually projecting that it's soon reaching its peak, and possibly it will just come down. Perhaps there might be a lower level second epidemic, but I believe that this work is still ongoing, and we want to see the trends and collect much data to make the predictions.
All right, thank you very much, Dr. Okonzi. Dr. Mweti, what would you like to say to that question? I'm sure, I know you mentioned that there is still a lot of data that has been studied. The recent introduction of the laboratories for genome sequencing, are they telling anything that would help answer this question from Rhoda Odiambo?
Yeah. Okay, I'll start, and perhaps my colleagues who are on the line might supplement as well. I think that, yes, there are a number of laboratories in South Africa, in Senegal, in Nigeria, in Uganda as well, that are involved in carrying out gene sequencing. And I'm sure Francisca can say even more about that, because I think she and Tiba and the other colleagues are involved in that. We believe that the viruses that are being seen circulating in Africa are viruses that have been circulating in other parts of the world, and particularly from Europe. Most of the importation of cases in African countries took place actually from Europe. This we do know, contrary to all the concerns at the beginning that we had about close interaction between China and African countries. And then we're also seeing, I think it's, I understand it's the G strain is dominant, and there have been other subvariants of this. And clearly there are mutations. What I've understood is that there haven't been mutations that have distinguished in terms of the virulence of the virus to any significant degree. The sequencing also enables us to see the pattern or what has been cases of importation between African countries. For example, we know that there have been some cases imported between South Africa and the Democratic Republic of the Congo. There's some evidence of transmission between some of the West African countries where there is a lot of intense population movement. But I believe that there is one dominant strain, which is a D strain, G strain, which was imported largely from European countries. And now, of course, as people are moving around, it is also being transmitted between African countries, and there may be mutations occurring, but I don't believe they've been so significant that we can say a different virus has arisen in a country and is behaving differently in the population than elsewhere. So perhaps I'll ask Professor Francisca to supplement that, because they're working directly on this.
Professor Mutapi has asked me to take it, Dr. Mweti. I hope
Okay,
that's okay.
Fine.
So thank you. We've done some quite detailed analyses of the 2,000 SARS-CoV genomes that have been produced by various institutes in Africa. It doesn't cover all the countries. I think it's about 16 countries now that are producing sequence data. Some of them, just so that we know, through capacity building programs that my organization, TIBA, put in place. And we're very happy about this, because if you remember the Ebola outbreak a few years ago, all the virus sequencing there was basically contracted out. It wasn't being done by African researchers in African institutions. The SARS-CoV-2 genomes, that's being done by Africans for Africans with some capacity building input. So that's very good. Dr. Mweti's summary is exactly right. Europe was the main source of the African strains. Even with the small sample of sequences we have, we can identify over 100 separate introductions into Africa. So we can clearly see that it was coming from Europe, high frequency. And again, just as Dr. Mweti said, spread within Africa was not the main issue. It was these imported cases. And the diversity of these viruses is considerable. It doesn't capture all the diversity of SARS-CoV genomes across the world, but quite a lot of it. So it's very diverse, and many different strains are there. We will continue to monitor this, but I think this is very important and valuable data.
Thank you very much, Professor Woolhouse. And I'd like to pose this question back to you, Dr. Mweti. In fact, it is directed at you. It's from Naftali Zinwa News Agency in Kenya. And the question is, are you confident that African countries are going to be able to flatten the curve before December? Basically, is there any light at the end of the tunnel, particularly for this year and how the virus is behaving?
Okay.
That's to me.
That's a critical question at the phase where we are, where countries, as I said, are needing to ease some of the measures that have played a very important role in reducing the transmission of the virus. So will they flatten the curve before December? I can't answer that question. I think what I can say is that the countries are very well aware of the fact that there are clearly defined interventions that will bring the transmission down. And they've done a lot of work to improve their readiness in terms of public health and to get the population to be knowledgeable, to be informed, and hopefully also to be equipped with supplies like masks, with access to water and soap or access to sanitizers that will enable them to play their role. I think we fully anticipate that as these measures are being eased, as we've seen in a couple of countries, there will be an increase of when people are moving around more, people are gathering more, there could be an increase in cases. What's very important is that the systems should be up to speed to be able then to address those transmissions and to bring them to a close without then having a wide transmission and a large number of people falling ill and people dying from the pandemic. So I think our expectation is that from what we've seen, I think Professor Woolhouse said it, that many African countries are opening up. We've seen an uptick of cases in a number of countries. I quoted some of them. South Africa, very much that exponential increase that happened in South Africa was after some easing of some of the very severe measures that had initially been put in place. Countries like Algeria, Mauritania, Ghana, Kenya. We're seeing in a country like Uganda, for example, that managed to keep the numbers down for months on end, an increase in cases that they started to open up. And I think what's most important is that the governments work with populations, work with civil society, work with institutions that help to analyze data, so that the response needs to be evidence-based and to the extent possible, localized. But what's very important is that the capacity should be in place now. If there's one thing that we need to have achieved with this very economically costly, drastic measures, is to have put in place the public health capacities to contain the spread so that we don't have widespread repeating itself in cycles in African countries. And I believe that a lot of this work has already been done, as we're seeing, and I think the next few months are going to be very important. Of course, while this is happening, we are very much placing our hopes on the vaccine that will play then next year. We expect a very determinant role in enabling normal life, as we will define it in the future, to resume, and a more definitive flattening and staying down of the curve. That's how I respond to that question.
All right, thank you very much, Dr. Amweti. If I could just, Dr. Okonzi, this question is actually posed to Professor Woolhouse because he spoke about it earlier on, but I think you could also weigh in on that if you can. It's from Pamela Mawanda at Uganda Radio saying, Professor Woolhouse mentioned something about Africa having its own kind of epidemic. What does the African epidemic look like, and how does it differ from, say, the ones in the UK? I mean, you also alluded to this earlier on when we were saying this is partly why the initial modeling was not accurate on, the level of the pandemic on the continent.
Well, that's right. I mean, the whole thing is that we are still learning about the character of this pandemic in Africa. What we can say at this point is that it is not exactly the same as this epidemic in Europe or in America or in Asia. It's different. We don't know the exact factors that are causing it. We just know that some of the factors are more probable, which have already been mentioned. The youthful population and outdoor, mobile, rural people, those kinds of factors. Those ones are known. But as we've said, research is required to characterize the disease and the pandemic in Africa, and this work is just beginning. So we really can't know at this stage exactly what has caused it to be different from the other places. We can't tell all the answers now.
Thank you very much, Dr. Okonzi. Let's come back to you, Professor Mutapi. There are quite a few questions that are coming in from colleagues. I know some of them may appear to be similar. But this question on the difference that we're seeing, the low recorded number of deaths, you know, looking back at a year from now, December 2019, is what Ochieng Ogbodo is saying. And the question is, what could be so unique about Africa that has so far somewhat kept the cases and deaths down compared to other parts of the world? As I said, it's continuation of the discussion, but perhaps if you would like to even proffer some more insight into some of the work that you've done and what it's showing us.
Thank you for that. I think I go back to what all the other panelists are coming back to. So we have low levels or low prevalences of the epidemic in Africa. So the infection process is lower in Africa. So we've looked at all the possible reasons for that. That might be people are more rural, more outside, and therefore less exposure to the virus. We're looking at perhaps better adherence to the mitigation strategies, the movement restrictions put on by governments. So that is reducing the infection process. Once people are infected, other factors are coming into play. So levels of potential cross-immunity that has developed from exposure to previous coronaviruses. We're looking at the youthful age because we know from studies globally that older people are more susceptible to disease and also more susceptible to poor outcomes of the disease. The youthful population that the colleagues have referred to is important. We know that with age, you get immune senescence, so the immune system might function slightly differently in older people. And we don't have that problem in Africa because we have a more youthful population. So I think the various stages of exposure, infection, and then disease outcome, those dynamics seem to be different in Africa, which is what both my colleagues were referring to in the African epidemic being different. So we need the measures of those specific differences from the African populations. What are the metrics? How infectious is the virus to Africans? And once it's infected them, how deadly is it? What is the disease process and the pathology that comes out that's specific in Africa so that we have context-specific information to be able to process this data? Thank you.
Thank you very much, Professor Otapi. Dr. Mweti, let me bring this one to you. It's from Vladimir Hernandez. So again, as I say, it's very clear that there is a theme here, and it's around this, the anomalies that we're seeing between Africa and other regions. And Vladimir points specifically to the difference between the spread of the virus in Africa when compared to other regions like in Latin America and parts of Asia, which have similar demographics, weather conditions, lifestyle, and levels of poverty. So how do you explain the difference? But also to talk about testing. If it's so low compared to other regions, are you then not concerned that there'll be a flare-up of cases? But also, how do you know, how are you sure that the behavior of the disease is then different?
Okay, thank you very much for that question. I think the question, how do we explain the difference between Africa and say Latin America, where there's despite the fact that the population structures might not be very different. So if, for example, if you take a country like South Africa and Brazil, which are one country in Africa and another in Latin America, which have been very severely affected. In fact, there's a lot of similarity between these two countries. They are among the countries where you get the worst inequities in society. So in terms of the conditions of quite significant proportions of the population living in urban, overcrowded areas, etc. So we have an African country, in fact, where the behavior of the virus has not been very different, driven by some of these factors, including overcrowded living conditions. And although the population structure may be similar, and urban lifestyles. So where you get a combination of good, if you like, a middle income country with good road networks, movement of people is very good, but some people live under conditions where once the virus enters into those communities, it's able to spread extremely rapidly. We also have similarities like patterns of disease in these countries. Even if the population might be a bit younger, you have a high prevalence of non-communicable diseases which predispose, for example, to severe forms of the disease. So that's why we have seen, we think, a slightly different picture there than we've seen in other countries. I mean, I think that we need to unpack the similarities and the differences going beyond the age structure of the population. There may be other things to do with the level of economic development, the intensity of movement, the types of structures in the society. And I think we can seek to understand that. It's true that we may have younger people in some Asian countries, but certainly the economic conditions are quite different from many African countries. The cultures, the way that people behave, the degree of urbanization may be quite different from the situation in African countries. I think we need to look at all of this. And then it has already been said as well that even the climatic conditions might be a factor in terms of temperatures, combinations of temperatures and humidity, and the way that the virus behaves then could be differences. What I think is that we need to break down and continue the analysis to understand what's happening. And most importantly, I think the other question that you asked, expressing concerns about testing and therefore possibilities that there are cases, infections that are undetected that pose a risk then of transmission showing up later. This again, we've acknowledged is affected. There's been a range of differences in the degree to which African countries are testing. We have to acknowledge the majority, more than half of the countries are testing at levels that are below 5 to 10 per 10,000 population. What's recommended is around 10,000 per population. And we are working very hard as the governments to increase the testing, to start to use some of the other technologies, rapid diagnostic tests to improve this testing. We think that carrying out surveys will be a very important supplementary activity to simply looking at reported cases, whether people be asymptomatic or not, that are showing up perhaps at health facilities.
So just to my media colleagues, we are nearing wrapping up the discussion. If you have some last minute questions that you want to put in the Q&A section, please go ahead and do that. Professor Woolhouse, I'm going to bring this question from BBC Africa to you. Although it talks about what the work that has been done from the WHO and ACDC, as in gleaning from their work, but basically the question is about sequencing of the virus to establish where it's being imported from. So it uses Kenya as an example, saying that the country has done an analysis of the virus and found that it was imported cases from European countries. So are we able to track and trace the pandemic itself from country to country, where it would have come from, which regions, etc.? And again, we'll go back to the question of, is there any behavioral pattern as a result of that?
Thank you very much. Some of those Kenyan sequences actually come from my colleagues in Tiba, Kenya. And they are leading our South-South collaboration in training other African partners in those sequencing techniques and the analysis of those data. So a big thank you for them for their contributions to this. We've been doing sequencing all over the world, and this virus turns out to be quite difficult to track. Its genomes are not as helpful as some other viruses are in answering the sort of questions we would like to be asking in real time. We will learn a lot from the sequencing data, and I think we've already summarized what we have learned from that. I'd also like to take the opportunity to go back to something very important that Dr. Mweti said a moment ago, and indeed, so it comes back to what's beyond age, what's important here. Now, just to reassure Dr. Sam that we did take into account age when we made some projections of what might go on in Africa in TIBA, and one of our predictions was simply on the age factor alone, the case fatality rate would be about a third of what we were seeing elsewhere, which is a huge difference. But we're absolutely right to say it's not the only thing. What actually allows this virus to spread is human behavior. It's who we meet, what we do, how we interact with other people, whether we wear face masks and socially distance. And human behavior, that is a very, very difficult thing to summarize, characterize, and compare, even within Africa. Never mind with Africa and the rest of the world. So that's what's driving this. And the two questions are linked because we would like to understand the transmission routes between different parts of society, different ways that people interact, different populations. And we can do that with the sequencing, but this virus is difficult to do that with. So we're learning a lot, but not all the things we would like to know about how human behavior drives the spread of this virus in African populations and around the world.
Thank you very much, Professor. Dr. Okwonzi, would you like to respond to that?
Well, I can just only agree with him. I don't think we have differences in the way that we're looking at the factors that are possible factors that are contributing to the pattern of disease in Africa. But as we have all agreed, it is not just about the young age. There are other factors that we have mentioned as possible, but we haven't got grips of exactly how they are making a contribution to the pattern that we see in real life. We need research, and we need to do more analysis and come to more concrete conclusion as to what is driving the epidemic in Africa.
So I'll give you all your final words. Just to say to you, Dr. Okoto, there's a question here from Linda Nordling. If you could also just share from your own experience. And Linda is saying that she's surprised to hear you as a speaker say that the youth profile is a major reason for the differences in the epidemic, given the fact that this would have been presumably included even in the early epidemic models that were predicted, which have seen much higher numbers. So population age structure would have been corrected in these models, no? So this is the question from Lyndon. Perhaps if you could just use that as your final word on this matter.
Well, I think she's just saying what we have just concluded on, that yes, everybody knows that age is a factor, but age has not explained everything that has happened in Africa. And so we are looking at the other factors that are driving it, that are driving the epidemic down. And we can only postulate. We don't know for certain what these other factors are. And I think I remember, Linda, we had a discussion on chat on some of these issues. All I can say is that Africa has been looked at as, you know, as being different, and that the population would be completely devastated, and it would not be as currently it is. And we are all wondering what happened to the African trend of the epidemic. But from what I hear Linda saying, this disease should have been much harsher in Africa. I want to disagree with her completely on this. I think we are human beings just like any other, and the characteristics of a disease are driven by objective factors in society and in the environment. And we are yet to look closely to see what these factors are. and we have not yet found out. Apart from age, we don't know what the others are. That's what I can say for now.
Right. Thank you very much, Dr. Okonzi. Professor Wilhouse, a final word from you?
Thank you very much. Two things, I think. First of all, I think it is right to emphasize, as Dr. Sam has done, that the projections for Africa at the beginning of this pandemic were absolutely dire, and they have not come true. And obviously, we all hope nothing like this will ever happen again. But we need to learn the lessons. We need to learn the lessons from that. It's such a stark contrast. The other thing I'd like to say is a thank you to WH-Afro and all their teams for what they're doing. And one lesson I've learned from this pandemic and the response in Africa to it so far is the tremendous value of working in partnership. We can do more together than we can do by ourselves, and we're demonstrating that on a day-by-day basis.
Thank you very much, Professor Wilhouse. Professor Mutep, how would you like to end off this in terms of what we should still be doing when trying to understand better about the disease and the role that academia can play in, especially those many unanswered questions, and some of the questions haven't even arisen?
Thank you very much for that. I cannot stress enough the importance of the work in Africa being Africa-led. We need our African scientists, our African research institution, talking to their ministries of health, talking to WHO-Afro, finding out what the context-relevant priorities are, and finding the context-relevant solutions. It is absolutely critical, because only Africans can put the priorities on the agenda for the rest of the world to work with us in trying to respond to this epidemic. So let's get our African institutions and research partners on board to lead the research in Africa on this and on future epidemics. Thank you.
Thank you very much, Professor Mutapi. Just a final question for you, Dr. Mutapi. I know that you're also giving your final word on this, but there is a question from Peter Mwai from the BBC, and it is posed to you, asking about Africa having a high percentage of asymptomatic patients that you mentioned earlier on. I think you put the figure at 80% for the African region. So Peter wants to know, what is it compared to other regions? And are they mildly symptomatic or asymptomatic?
Okay, thank you very much. I think, and I do think this figure we need to monitor to make sure that there's something that sustained this very high percentage of asymptomatics that I was told about. We've seen, for example, in most other countries, in Western countries, it's about 40% is what has been the estimate. So people who are asymptomatic, and then those who are in the early phases of the disease. Apparently in France, the figure is about 51%. And I think there's a kind of transition in between being completely asymptomatic, meaning there's somebody who will not get symptoms, who will go through, if you like, the infection and recover from being infected without becoming ill. And then there are some who are counted as being asymptomatic, who are infected in the early phases and then get ill later. So those are the figures for other countries. I think, of course, we know that people who are asymptomatic are capable of transmitting the virus. So I think that should not make us feel complacent in terms of the risks of transmission, and therefore the measures that need to be taken by everyone. And then if I have your permission to say a last word, Tsepiso, I'd like to just come back to Dr. Sam and his introduction and his expression of essentially a concern and objection at the immediate assumption that, you know, Africa is that terribly hopeless place. Of course, if there's going to be a serious problem, it's going to be devastating over there. Nothing's going to be done to do something about it. We talked a lot about what could be some of the factors that have come into play, if you like, natural factors, exposure to previous infections, and population structure. I think one thing that we do need to acknowledge is that African governments did take action very early at the start of the pandemic. I think this needs to be acknowledged in its real value because it made a difference. And as I've said earlier, it made a difference at a high cost. We know that, for example, in a country like South Africa, it's estimated that the GDP is going to be reduced by over 50%. So what I think is that perhaps because they are more familiar with having to face up to outbreaks and epidemics, African governments took, and of course, of all the discussion about their systems are weak, they're so vulnerable, they took very tough decisions early on and imposed very drastic measures. And I think the social and economic impact of these is something that's going to be quite profound. So it's at a high cost that this is coming. So I do think it needs to be acknowledged that they took these steps. They were tough, courageous, very costly, and then the populations have also responded in certain ways. And what we need to do is to sustain this so that the cost is then, if you like, justified somewhat by the fact that we don't have upticks, we don't have exponential growth coming again, and we can as soon as possible start to normalize things and for the economies and livelihoods of people to start to recover. That's what I'd like to say as the last word. And thank very much my fellow panelists and especially the colleagues from TIBA. I second that, that call for collaboration very strongly, and I'd like to say how much we appreciate the collaboration with you. Thank you very much. Thank you, Sepiso.
Thank you very much, Dr. Mwete. As you mentioned earlier on, that the WHO has invested quite a great deal of technical resources and monetary, I think you said an amount of $320 million through the partnerships that you've had. And I think my colleagues would agree that through this discussion, it's been very clear that there has been a lot of in-depth research and data that has been coming out of this, and there's a better understanding, at least from us, on what we're dealing with, the type of behavior that the pandemic has shown. So thank you very much for a very rich discussion and report from Dr. Matshidiso Moeti, WHO Regional Director for Africa in Edinburgh in the UK, Professor Francisca Mutapi, who's the lecturer in Global Health, Infection and Immunity. Thank you very much as well to you, including you, Professor Mark Woolhouse, lecturer of Infectious Disease Epidemiology at the University of Edinburgh as well, and Dr. Sam Agatwe-Gonzi, Chairman of the Hospital Management Board, a regional referral hospital in Uganda. It's been a very enjoyable discussion. Thank you to all of you. Do enjoy the rest of your day. That's how we come to the end of our briefing.